us for this association, Press Association of Jamaica Public Forum. We're so happy to have you with us. They say it's so nice you had to do it twice. So we're so happy that our panelists are back with us. I'll introduce them properly in just a little while, but to kick off the proceedings, let me ask our president, George Davis, to say a few words. Okay. Okay, my apologies. We don't have George right this minute, but that's okay. Let me just welcome you all so much for being with us. It's a tradition of the Press Association of Jamaica always to invite dialogue, public dialogue on controversial issues, issues that affect the profession, issues that affect the media, and to have some of the best minds in this particular area to come and to share with us. And that's what we're going to be having this evening. We're going to be hearing from Professor Marvin Reed, from Dr. Roger Hunter, from Nagima Ragabir, who is the president of the Association of Caribbean Media Workers. And in fact, we're going to start with Nazima to give us an idea of how this issue of balance, media balance, working throughout a pandemic, when you have all these different voices, minority voices, majority voices, mainstream voices, and everywhere you turn, people are clamoring for space on the platform. Is it okay to shut out some voices in the interest, they say, of public health? Well, let's find out. Over to you, Nazima.
Thank you so much, Dion. And it's so good to be here again. I feel energized after our battle on Monday. And it's so good to see Dr. Reed here again tonight. I wanted to touch on a few issues. I think this is a very important topic. Congratulations to the Press Association of Jamaica for pulling this off. I think this is where the media comes in facilitating this type of discussion, because it's certainly informative. It certainly gives you an idea of the views out there, and you certainly get a chance to listen to some of the issues. I wanted to bring my media background and to let the public understand what is expected of the media as we report on the pandemic. And our work outside of the pandemic generally is rooted in fact-checking information. You have to be able to fact-check information. You have to be able to investigate the information that is before you. And that is the general crux of what we do in the media. Anything that comes before us, you ought to be able to investigate that information. You have to be able to fact-check that information. And there are several things that you do when you're fact-checking that information. You check the source. You check whether or not the source is reliable. You check whether or not the source is getting its information from reliable sources or some sort of reliable platform that information is coming from. Where the pandemic is concerned, your information, you have to be very careful where you're getting your information. And as media, I think that is where the battle has been from the onset, where we get that information, who is giving that information, and the accuracy and credibility of that information. If you've been reporting on the pandemic, or if you've been working on any issues related to the pandemic, at least where public health is concerned, you know exactly where you're getting your information from, and they're credible sources. I know a couple of media houses. You have in the varying countries, you have your Ministry of Health, you have your Chief Medical Officer. There is PAHO, WHO. There are a lot of people and a lot of journalists, who rely on those interactions with these agencies to get accurate information for the public. And of course, as media, you depend on the journals like the Lancet, where you see peer review information, stuff that is filtered in a sort of way and written for journalists to report on. You depend on those sources for the types of information that you're hearing. what is most important in all of this, and what we do as journalists, is that you have to be able to corroborate your information. And when you see information out there that continues to be peddled, that can't be substantiated in any way, the media has to take a lesson out of that. Is it where you get on the wagon to ensure that you work on fighting that disinformation? What is your role in that entire process? And these are some of the things, I hope we can discuss here tonight. um More than anybody here, and journalists know the importance of freedom of expression, freedom of the press, but freedom of expression in its wholesome term. It's one of the things that is rooted in the type of work that we do. But in understanding what freedom of expression is, we also understand that it does not give you any absolute power to say and do as you feel or as you wish. It comes with responsibilities. And that is one of the things in this public discourse on the pandemic, you have to constantly ensure that you're on top of. Uh, and I've seen some. I can't say stories because a lot of them don't come from credible news outlets. But you've seen social media. You've seen people who have said things about what they have done, what they've used, and why they shouldn't use this, and sort of battling the type of information that is out there when it comes to vaccines in particular. And some of it has been very troubling, I must say. I mean, I've heard a lot of stories and people saying to me, oh, I've heard this person took the vaccine, but then they went to flush the vaccine out of their system. And I've seen stuff like that on social media. And I want to say this as one of the things that I want to touch on. COVID remains very personal to all of us. It is still a live pandemic where changes are happening, and it is going to be like this for quite a while. We will have to adapt, we'll have to understand the pandemic, and we'll have to understand what comes with it, and the fact that it is going to be ever changing, at least for as long as it is here. And our understanding of the pandemic and those changes, we will have to get with it each and every time as media. One of the things I want to touch on as a very last point tonight is that the issue of self-regulation and how we decide what content we carry and what content is necessary. I know media houses have their own self-regulation policies, and media entities have their own self-regulation policies. And sometimes it could be that with this discussion, we go back to the drawing board to decide how on whether or not we provide that so-called balance when it comes to discussing vaccination hesitancy and the pandemic, and who or what is being said should be given an outlet. So I'll just stop there and allow for the other presenters to present tonight. Thank you,
Right.
Dia.
Thank you so much, Nazima. And did I mention that Nazima was the first woman to ever hold the post as a president of the Ghana Press Association? So she herself makes history and breaks through borders. Now, before I go to our other two panelists, let me go now to President George Davis for his remarks and welcome.
Thank you, Dion. Thank you, Dion. So happy to have everybody reconvened for this very important event. And thanks to our panelists for making space in their diaries to assist us in this regard, because yeah, there are several things that I'm sure people want to have said and to have challenged that will be discussed over the course of the meeting. Discourse like this is always good, can only be useful for people like ourselves who are opinion makers, opinion shapers, and who report the news. It's a very crucial debate that has emerged out of, as I said in a greeting last week for the aborted session that we have. We were talking with the head of prominent agency who said that leaders in the healthcare, in a particular healthcare group, were concerned about the reportage from this part of the world, as so as to suggest that, the information about COVID-19 and vaccines and everything else, and how that was being crowded out or being given equal space as persons who were anti-vaxxers or persons who were pushing what they would call conspiracy theories about COVID, and that as if to say that that is what and how journalists have been covering the issue. We took issue with that because we're saying no, and in an event, there's a fundamental principle of fairness that attaches itself to issues like these. If someone is saying the sky is blue, it is incumbent upon you to give space to somebody else who's saying no, the sky is black, and then you allow the audience to make up their minds. Persons are saying no. In a pandemic situation and in the situation we find ourselves in, where persons don't want to take the vaccine, are openly anti-vax, and are saying that COVID is, well, it started as a 5G issue, it started as a China issue, and all the other spurious claims about its origin. People are saying that the principle had to be abandoned and there couldn't be what we call fairness displayed. We felt that it was necessary to put that to the test, to have experts debate the topic, and to also give the public a foot into the conversation, because perhaps it is, and of course we expect things to emerge from this discourse that can help us to sharpen our own tools as we practice the vocation. So I'm very happy that everyone is here, and I look forward to a robust discussion.
Thank you so much, George. Always robust when we have journalists in the house, and also the critics of journalists. And we welcome the criticism, because that's all part and parcel of what helps to make us stronger and move us forward. I'm going to introduce now and ask to speak Professor Marvin Reed. Now, he's Deputy Dean in the Faculty of Medical Sciences at the University of the West Indies, with a PhD in community medicine, as well as having helmed several of our major health institutions, such as the Sickle Cell Unit, such as the Tropical Metabolic Research Unit. Professor Reed has a wealth of experience in community and public health issues, and he has been a leading voice during the COVID-19 pandemic. Over to you, Professor.
Association of Jamaica for inviting me to share my thoughts on this very important topic, which basically seeks to have a debate on whether or not, in the presentation of information to the general public, whether or not balance is important. So, as typical for most of us in academia, we like to say what our disclosures are. And the reason for that is not for boasting, really, but it's really for the audience to assess the information that we're given, to see whether or not the information we're given may be biased in any way. So for this particular talk, I really have nothing specific to disclose, except to say that I've built a career on science, and most of that activity revolves around testing medicines in humans to determine whether or not they work. So I'm going to commit the cardinal sin in debates by giving my conclusion first. And the question posed is, should anti-vaxxers have a voice? And I will say yes. So in trying to understand why I came to that conclusion, I'll create some form of context for us. So first, I'll describe for you really what do we mean by science and the scientific method. And then I will describe for you what are the medicines and how these will work, how we test them, and in particular focus on the whole concept of vaccine and vaccine hesitancy. So science really is an approach. It's really an approach that we take to give an answer to a specific question. The question in science jargon is often called the hypothesis. And the range of approaches that we use to actually test or provide an answer for that hypothesis is collectively what we call the experimental design. Scientific progress has been undeniable. All of us recognize that how we used to operate 20, 30 years ago is currently not how we currently operate and exist. But the progress of science tends to follow an up and down pattern over time, even though the slope or the rate of progress tends to be positive. And what contributes to this, what we call oscillation in terms of scientific progress? Oftentimes, some of these oscillations and peaks is really due to the fact that contrarian views, people who have opposite views to the majority, contribute to these scientific peaks. So in terms of medicine, the standard method that we use and the gold standard method that we use for medicine development really revolves around a technique or an approach that we call clinical trial. In this approach, what we often do is that we give the medicines of interest that we're trying to test to see whether it works or not to a group of individuals. And simultaneously, we give another group of individuals standard treatment or a placebo. A placebo here could be like a sugar-coated pill, so we don't expect that to have an effect. And then we compare after a period of time the outcomes in the group. So why are clinical trials important, and why is it that we need to base a lot of our decisions in terms of interventions on the results of these things? Essentially, a clinical trial as an approach tells us whether medicine works or not. It also allows us to determine the benefits, the magnitude of the benefits that are to be derived from the therapy. And more importantly, it allows us to objectively assess what are the side effects and how common these side effects are likely to be. So within that context comes vaccines. What are vaccines? Vaccines, in effect, are just medicines. They are medicines that train the immune system to fight an infectious agent and or their products. So one of the things about vaccines is that they're the most utilized medicines worldwide. They're the medicines that mankind uses the most throughout the world. Vaccines have a reputation of saving life, and they generally work by reducing serious outcomes in the recipients, as well as reducing transmission of infections in the recipients. However, this latter point about reducing transmission of infection is not necessarily an intrinsic property of the vaccine in itself, but really refers to the fact that if many persons within a community are themselves vaccinated and have some resistance to the infectious agent, then you will end up having what we call a population coverage or herd immunity, so that infections cannot be propagated from one person to another person relatively easily. So Jamaica has had a strong history of, or a strong vaccination program. On my left, I've indicated and I've shared what are some of the vaccines that I've received so far over my life. On my right, I've shared some of the vaccines that a typical teenager in Jamaica would have received. And I've highlighted in red the rotavirus vaccine. And I've highlighted that because of the fact that the development of that vaccine, the Merck brand, actually a significant proportion of that development occurred right here in Jamaica. And as a result of the clinical trial that we were able to do around this vaccine, we now have a vaccine that prevents individuals from dying from gastroenteritis or diarrhea from gastroenteritis or running belly. So if you look at the bottom of the slide, basically what we're trying to demonstrate there is that certainly Jamaica has a strong tradition of having immunized individuals within the country. Typically over 90% of us are immunized. So that brings me now to the COVID-19 vaccines and to a large extent the subject of the talk. Now, COVID-19 vaccines are only different in the fact that they are produced using a range of technologies. We have the traditional technology, those that are produced that way. For example, the Sinopharm is one that is produced using the traditional technology. And we have those that are produced using newer technologies, the so-called mRNA vaccines. So for example, the Pfizer and the Moderna. But irrespective of the technology, COVID vaccines are similar to all the other vaccines that we have created. That is, from an efficacy standpoint, that is how they work, essentially is that they reduce serious complication, and they work whether or not the person has had a previous COVID infection or not. More importantly, they also protect newborn infants of mother who receive the vaccine in pregnancy. So if they do all of that, why do we have this whole concept of vaccine hesitancy, which the World Health Organization has defined as delay in acceptance or refusal of vaccines despite their availability? The World Health Organization has created for us what we call a paradigm that allows us to try and figure out why this is so. And this paradigm says essentially that there are 3 C's that contribute to vaccine hesitancy. Complacency, that is, individuals don't believe that the disease is going to cause them serious harm. Confidence in the vaccine and in those that are promoting it, and whether or not it's accessible and convenient for them to take it. Having said that, hesitancy is a spectrum. So you will have those individuals who have some resistance to specific vaccines, and you'll have those individuals who do not require, are opposed to any form of vaccines at all. Typically, those individuals are what we call anti-vaxxers, but they just constitute a small proportion of the individuals who tend to be hesitant. Concurrent with this pandemic, or viral pandemic, is the so-called concept of infodemic, which is really an excess information, including false and misleading information, which may occur both in a digital and physical environment, right? And the challenge we have with the infodemic is that it provides a platform for what we call vaccine hesitancy. So what are some of the characteristics of this infodemic? You have the creation, the production and reproduction of these information, and the distribution. There are some facilitators of the creation, as well as there are some facilitators of the production and reproduction and distribution of these bits of information. So the question, though, is that we recognize, certain those of us in public health, that vaccine hesitancy can harm and even kill you. It can harm your neighbor, your family, and your family members. We recognize that as part of this infodemic approach, anti-vaxxers frequently attack issues related to confidence in the vaccine, as well as try to induce a state of complacency. And as I said, the pandemic provides a fertile ground because there's lots of fear and uncertainty related to how it is, the effects of the virus will have on us. And the other additional issue that we face in this time is a greater accessibility to communication tools. So from a public health standpoint, and even from an individual standpoint, there's certain consequences to your vaccine hesitancy. There's the economic consequence, there's social and cultural consequence, and from a public health standpoint, we focus a lot on the lives lost and the disability that occurs because individuals get infection and they are not able to recover completely from those infections. So they have long-term disability. So why should anti-vaxxers have a voice, having described the ill effects that can come from vaccine hesitancy? Well, we have to be practical. The truth is, we really can't stop them. There's also this ethical principle that certainly an adult individual has autonomy over their bodies and their choices. We have how society is organized, and therefore in a democratic society, we do allow for variations in thought and variations in opinion. And some will even say that it is codified in legal constructs such as the Constitution. From a scientific standpoint, one of the things that we recognize that has happened during this pandemic is that the anti-vaxxers paradoxically enhances scientific literacy. And one of the other things that has emerged is that the pandemic has revealed that science is not really a linear entity. And because a lot of what is occurring in our labs is actually happening out in the public. So individuals in the public get to see the good, the bad, and the ugly of science. And is this bad? The short answer is no. Because if one understands the principles under which medicines are developed, understands the principles on which interventions are proposed, then I think one is in a position to make more informed choices. The other things that the anti-vaxxers has forced us to do is that those of us in the scientific community really have to enhance and brush up on our ability to communicate not only amongst ourselves, but also to communicate with our stakeholders, with our clients, with you, the public. And therefore, with said all of that, I think what we need to do is, yes, to assure balance, but in assuring the balance, we on our side, those of us who are pushing for what we consider to be evidence-based medicine, need to ensure that we utilize all the tools that the anti-vaxxers are using so that we can share with you, and this is one example of it, so we can share with you in a more constructive manner how things work so that you can actually make informed decision. So I'll end now where I started. Should anti-vaxxers have a voice? And my short answer is yes. Thank you so much.
Thank you so much, Prof. I mean, I was just taking notes while you were speaking there. I have so many questions building up, but let's wait until the end of all the presentations. So let me at this point introduce Dr. Roger Hunter and ask him to deliver his presentation. Now, Dr. Hunter has also been one of the voices we have been hearing throughout this pandemic. He is a firm advocate of early intervention in COVID. He is Chief Executive Officer of Medical Strategies and early home-based COVID treatment practitioner, and he has in fact delivered quite a few seminars and talks on that particular issue. Over to you, Dr. Hunter.
Thank you, Dion, and thank you to the organization, to the organizers, the PAJ, who have invited me to talk today, this evening. Sorry that we didn't have the conference going ahead on Monday, but there's opportunity here as well. I recognize and acknowledge my colleagues as well, and of course, special regards to my friend, Dr. Professor Mervyn Reed, somebody who I admire quite a lot. Unfortunately, this topic is a little bit difficult in the context that there are no true anti-vaxxers on the panel. So, in other words, I don't think there, from what I heard on Monday and from what I know now, there are no persons here within our midst who really do not support vaccines any at all. I know there are particular groups who do not support vaccination whatsoever, and perhaps the Rastafarian community, certain elements within it, certain branches within ultra-Orthodox fractions within the Rastafarian community, within the Jewish community, and I think also in other cultures, I think also in some aspects of the Muslim community. So I think to give justice to this topic, we are somewhat constrained. But what I'll say for absolute clarity, without any hesitation, without the use of double-blind randomized controlled trial, without the use of science, every human being must have a voice within this space called COVID. They absolutely must have a voice to determine what happens to themselves and within their sphere of responsibility. For instance, if they have a minor, who they're responsible for, they absolutely should have a right to determine the best way forward for that minor. So to answer your topic very clearly, very loudly, 100%, without any hesitation whatsoever, anti-vaxxers, those who do not support vaccinations whatsoever in whatever form, they absolutely must have a voice. They should have a voice. And by a voice, what I mean is not just a voice within their neighborhood, within their local environment, but on a national platform. I'm a firm believer in democracy. I'm a firm believer in the freedom of speech, and I'm a firm believer in free speech and a free press. Unfortunately, from what I saw from the information that has been carried within the COVID space, and this is much larger than vaccination, let us be very clear, the news tended to follow a particular pattern, which perhaps the science said. For instance, if the science said we shouldn't wear masks. We didn't wear masks. As we heard from the WHO said masks were not important in regards to people who are asymptomatic. And we also heard that echoed by our chief medical officer. Now, that went against every principle, every fundamental principle of infectious disease. But we heard that, but, went along with it until fundamental testing and application, just looking how the disease progressed within society, realized that that change of thought echoed by the mass media was incorrect, that people who are asymptomatic can spread a disease, an infectious disease, for instance, HIV. If you're asymptomatic, you can spread HIV, hepatitis B, and also COVID. So we've seen a lot of evidence within the whole COVID story of information being carried in a particular manner, in a particular context, in a majority context, from mainstream, so-called mainstream media, and it was left up to alternative media to carry the alternative voices. You may decide to agree with it or not, but there is an absolute important place for the alternative media, the social media, for instance. But there's important voices. We must hear the voices. The thing with evidence-based medicine, and I'll focus now towards vaccine, but I'll say this: the fundamental problem with what my learned colleague, Professor Marvin Reed, has said regarding evidence-based medicine and class 1 evidence is that it is inherently biased. It is biased towards giving positive results. So, for instance, if I develop something, I tend to produce or publish, oh my God, this is working brilliantly. And yes, this product is absolutely amazing. So I publish those results in the positive context. But I don't tend to produce results in the negative. So if, for instance, this hurt people, I tend not to produce that result. And unfortunately, COVID has not escaped that context, whether it's vaccines or what is purported to be vaccines, or even emerging treatments, which are now coming into the fore. So it's very important that we understand the fundamental problem with evidence-based medicine, evidence-based science. Now, when you marry the two with a mainstream media, instead of allowing the evidence to be examined by critical thinkers, you announce it to the world by Time magazine, by Time News or CNN, BBC. You don't allow the medical establishment to properly examine this information. Then what you tend to get is a runaway news of positive. Oh, these results are 97% positive, 97% confidence. But when we start to apply it, we then find problems. We then start to find issues which were never announced when the 94%, 95% success rates were announced. And that's a problem. We have to be careful, therefore, in balancing a conversation, that we don't allow the feel-good effect and to get ahead of fundamental issues. We need to allow the experts, so to speak, in science to properly, critically analyze the information. People who are independent, people who did not have anything to do with developing the product, be it a vaccine or a drug. People who know, like myself, and I have my stethoscope today. Yes, I'm a neurosurgeon, but I'm a clinician. I'm a doctor and I'm a clinical medicine practitioner, first and foremost, before I'm a surgeon. But what I'm saying is that when we apply the treatments or the interventions and we get different results, we become challenged and say, well, Pfizer or Moderna or BioNTech did not announce these things. And so you automatically become a naysayer, someone who is vaccine hesitant, or you are an anti-vaxxer. I'd like to say it very clearly that I love vaccination. And vaccination was brought to the Western Hemisphere by an African by the name of Onesimus. In fact, his master, who was an Anglican priest, an Anglican minister of the cloth at the time, was almost killed. His house was firebombed because he took information from Onesimus and said, well, you know, if you inoculate people with the smallpox who are well, a lot of people will survive if they should get full-blown smallpox later on. And that was introduced to the Western Hemisphere a couple hundred years ago. And to this day, smallpox remains the only disease that have been completely eradicated with vaccination. So it's very important that we understand that I love vaccination. I completely support vaccination. What I do not like is rushing into something without properly analyzing it. We have good reason not to like it. There is a particular study called a NACIS study, the NACIS 1, NACIS 2, NACIS 3 studies from the 80s and the 90s. Hundreds of millions of US dollars were removed from doctors. Doctors were sued. Doctors were sanctioned. Doctors were fined for not applying steroids, which had been around for several decades. Steroids were not new. They were around for several decades. If you did not give steroids a medicine to someone who had a spinal cord injury, if you did not give steroids within a certain time frame, then you were absolutely negligent. And many doctors were sued. Many doctors lost their license. But the problem with the NACIS 2 is that they set out trying to find out if steroids, when given, would improve outcomes with spinal cord injury. And the primary purpose of the study was not met. So guess what? Instead of announcing that the study was a failure, the primary objective was to improve or to reverse disease. It did not meet that criteria. They then looked within that study for particular aspects of it and said, oh my God, if we can do a subgroup analysis, we found that if it's given within 8 hours, it may actually be beneficial. And if it's given within 3 hours, it's beneficial. And so for over a decade, you had to mercilessly give steroids to people who had injured their neck from trauma, motor vehicle accidents, fall from a tree, from whatever cause, from a birth delivery. And if you dare not give that steroid, you were crucified. But when the clinicians put on their stethoscopes and started to apply this, they found that their patients did not suddenly get up and walk. There was absolutely no benefit. But what was worse, after 10 years, what they found was that there was more harm done than good. After 10 years. And you know what that class 1 evidence was relegated to? To the dump, to the waste heap of medicine. Here it is. Steroids were around. They were safe. They were proven to be effective. And we have been used to steroids over for many, many years. So why should there be a problem? Simply just reusing. It was always in development. But guess what? After 10 years, we found that that actually was not so. And that more patients were harmed than any benefit was ascribed. Sounds familiar? That NACIS 2 was announced to the world through CNN, Time magazine, instead of being allowed into the purview of doctors who are inherently skeptical to say, let's see how this actually, when I use it in Porus or in Eldersley or in the districts, let me see how it really works. And we realize it's not working. We're seeing a lot of problems. And I'd like to just share one slide with you. And I'm not an anti-vaxxer, but I absolutely believe that people must be given the opportunity to analyze for themselves what should be put into their body, whether by mouth or by the vein or by an injection. Let us share this with you, and I hope I can share I'll just share one slide for the interest of time. She's upload file. Oh, here it is. Oh, it's not allowing me to upload. But essentially, it's a lady, and this is one of many examples that we heard nothing of when AstraZeneca was announced, when Moderna or Pfizer. This lady's skin 2 weeks after getting the AstraZeneca vaccine last year, April, massive excoriation of the skin. Hundreds of thousands of dollars later, and still in pain and disability. Perhaps she wasn't given the opportunity to decide for herself, because the vaccines were told that it is selfish. We had people who are ethical, who are bioethicists, saying people who don't take the vaccines are selfish. No, when you have this toxic sort of conversation, and when you have the mainstream media allowing certain voices to predominate, then science absolutely loses. And we have to resort to alternative strategies, such as YouTube, to get information out, such as basic information. To this day, Jamaica has not heard that oral hygiene is absolutely crucial in reducing the transmission of the virus. No, when I say Jamaica hasn't heard, and perhaps the world, from a mainstream stage, from the stage of the Ministry of Health, we have not heard the emphasis on oral hygiene. We have not heard the emphasis on pulse oximetry. We have not heard an emphasis that if you intervene early rather than isolate and wait for a vaccine, which is said to be 97% effective, 100% effective, but that there's no treatment until the vaccine. Some people, the vaccine was so marketed that it was even thought to have been treatment. And there are several examples of people who knew that they had coronavirus, but they actually thought by getting the vaccine, which is a medicine, right, that they would actually improve. And one thing was clear: the developers of the drug knew that if you should get the vaccine and have COVID at the same time, you would have something called a cytokine storm, and it would be too much. And several people have died from being vaccinated whilst they had COVID. We didn't hear this metered voice. I'm not sure. You can guide me if my time has gone a bit much.
Yes, you're just about out of time, in fact, Dr.
There's
Hunter.
a lot to say, but I will yield at this time. And I think people got the gist of what I'm saying. Anti voices, I'll say that. I won't use the word anti-vaxxers, but alternate voices must have a voice. I yield.
Thank you so much. Before I go to any other questions, there are a couple I just want to clarify, for instance. So is it that, because what I heard you say, what I wrote down, you said the problem with evidence-based science. Could you just explain that? I'm not sure I understand that sentence, because I thought evidence-based science, in fact, is the gold standard, is what we're all aspire to. I want to ask Professor Reed to respond, but before that, I would like you to clarify that sentence.
It is one of the most dangerous tools in medicine.
Evidence-based science.
It is one of the most dangerous tools in medicine. I gave you the specific example of the North American Spinal Cord Injury Study, Class 1 evidence, Dion.
No, hold on. Okay, hold on. But if it is that we're not to use evidence-based science, then on what basis are we to evaluate medicines and treatments? And as I said, I'm going to go to Prof. Reed, but I do want to.
I want you to be
in
absolutely
clear. In short,
we asserted people's individual rights and clinicians' individual rights to apply what the clinical trialists tell us to our particular circumstance. So we must be cautious. Doctors are traditionally cautious in how we apply a particular study. We have applied treatments, right, the vaccines, and we are seeing a number of side effects. When you have the chief medical officer of a hospital being afraid to report the side effect, that tells you that evidence-based science is constrained.
No,
Evidence-based
no, no.
science
Sorry,
is,
doctor.
is
Sorry. No, I'm going to interrupt. Sorry. No,
fundamentally a
hold on.
tool that's used to,
No, hold
to
on.
guide
No, man, hold
how
on.
we practice.
What you're describing, just before I got to Professor Reed, and I know this is Hill's wheelhouse, but what you're describing doesn't sound to me like a failure of evidence-based science. It sounds like a failure of processes. Because when you're saying somebody is afraid to report adverse results, that's all a part of the process of data collection and evidence collection. Negative results are as much a part of research as positive results. So what I
We are,
hear you describing is not a problem with evidence-based science. It's a way in which the scientific method is applied. And I would argue scientific method gone awry.
because evidence-based science is tend to be good news, good news, good
No,
news,
no,
not
no,
about bad news.
no.
Remember the
Evidence-based
media,
science is
the
exactly what it
media,
says, evidence-based. And the evidence may point you to a negative result as well as to a positive result.
and we never get wind of it because it's not published. Can't you
Okay.
understand? It's not published. It's hidden under file 22 in
Which
the
is why,
desk.
which is why I'm saying
It's
what you're
not published.
anyway. Let me ask Prof. Reed to answer, since this is actually his area of expertise. Prof.
Right. So the short answer is, as a discipline, we're moving towards adopting evidence for or to inform whatever activities we do. So as I will try to explain, what do we mean by that? We mean we rank evidence. So there are some kinds of evidence that have higher rank than some, but the truth be told, what my learned colleague is really describing is what is called a publication bias, which has nothing to do with the actual evidence itself. Evidence is never static. Evidence will change and evolve over time as new evidence emerges. All right? So we can't have a position now, 2020, and expect that that position in the light of new evidence will remain the same. It will change. The best kind of evidence is in the form of what we call clinical trials, when you simultaneously compare groups of individuals at the same time. Some evidence can occur if it is that you, based on your own experiences, you give a particular intervention and you see what happens and you write that up. The issue with that is that you never know whether those kinds of treatment ever really work or not. And so that kind of evidence, although it may give you a signal, is considered to be very weak evidence. So the problem, as you rightly pointed out, is not necessarily evidence-based medicine is bad, is the fact that, one, evidence-based medicine is based on certain standards, and the issue is that those standards will evolve as new evidence emerges over time. The truth be told is that if you do not depend on evidence to make your therapeutic decision, then in truth and in fact, what you're depending on is faith, that I'm giving you this in the hope or that it will work. The truth be told is that the profession that deals with faith, that's their raison d'etre, is really my religious leaders. That's really those sort of things. As a physician, my goal is to really to treat my patients based on the best known evidence that there is.
But can I ask you to address the point that Dr. Hunter made, though, which does sound like an important point? So you reframed it as publication bias. Yes. So fine, but let's address that. Because if, as Dr. Hunter is asserting, what we have is that we only get the positive results being published, no one knows of the failures, then surely that must be problematic as well.
And
so
that speaks to the processes. So we recognized over time that that was an issue. And over 20, 30 years ago, there was a concerted effort to try and ensure that publications are published or people publish, whether positive or negative. And so right now, which is why we speak about this clinical trial things, before anyone can engage in a clinical trial, they have to list it on what's called a repository. And after a time, they have to say what that result is, whether it is positive or negative. So we have instituted in the scientific community processes that will try to ensure that both positive evidence as well as negative evidence come to the fore. So it's not absolutely true that because of the fact that there is a tendency not to report negative findings, that in itself makes evidence-based medicine faulty.
There's something I want to put to all of you in turn, which is, so everyone has a voice. Everyone deserves to have a voice, free expression, and all of that. But what about the responsibility of media? Media codes, for instance, speak to the importance of not putting out misleading or incorrect information. And let me introduce what is called false equivalency. Right now, this is when media portray two sides as being of equal weight. And most, apart from the COVID issue, we've been criticized for it we meaning media across the world have been criticized for it very significantly during the coverage of climate change. Whereupon you have a situation where 99.9% of scientists say climate change is real, 0.1% say climate change is not real, and that 1.1% is probably sponsored by the oil companies. And yet, when you look at a talk show, you say one scientist say climate change is real, you say another client saying scientist saying climate change is not real. So the public is left with the impression that these two views carry equivalent weight, false equivalency, when it's not so. And a lot of critics and writers and commentators say this, in fact, has fueled the climate denial movement across the world and led to a lot of skepticism in the public and a lack of understanding as to the real position of science on this issue. So let me translate that into the COVID situation, where we have a majority of scientists saying, for instance, the vaccine is necessary, the vaccine is important. Yes, there are some, as Dr. Hunter pointed out, yes, there are some adverse outcomes, but they're by far in the minority. But when you hear, if you put that view up against someone who says, blood clots, skin conditions, all kinds of problems, and people are left with the impression that maybe it's a 50-50 outcome. If I take the vaccine, it's 1 in 4, it's 1 in 2, maybe that I may have one of those adverse outcomes. So what is the responsibility of media? How do you then frame voices in that kind of situation? Nazima, let me start with you.
Thank you, Dion, and a very spirited discussion. I truly enjoy it, and this is the type of discussion. This is the type of public discussion I'd like to see from professionals, from experts, from the scientists, from the doctors on this particular issue to inform media discussions and to inform public discussion on the pandemic. One of the most important points that you've touched on is the media responsibility, which brings me back to that the decision-making process when we're covering stories and we're putting stories out there. Finding the balance, everybody wants to find a balance. But nobody wants to really make that definitive answer when it comes to public issue. Let me just say this. We have no control over skepticism. I stumped my toe today and it's caught on video. You can find some people saying I stumped my toe and some people saying that I didn't stump my toe. The reality is you have to be able to present whatever facts there are and find the experts, find the resources, and find the necessary information that is there about what is being presented and provide those voices. And I do believe both of my co-panelists tonight, I do believe some of the statements that they're making, and I do endorse those statements, because you have to be able to present that information and present that information to the public. And I think this is why we need more of this type of discussions. This is why we need this type of expert informed discussion on particular issues, because it's not only the media's responsibility, and that is what we found out in this pandemic and so many other things that are happening. It's not only our responsibility, it's about the people who have the information who really got to come to front. Thank you.
Dr. Hunter, your thoughts on that?
I love her comments. It's absolutely beautiful. I mean, I wish we had 24 hours to discuss this topic. and I guarantee you it still would not be enough. We heard a lot, We heard a lot in the past 2 years, a whole lot. Suppose I told you when I treated COVID patients, I didn't wear masks, I didn't wear PPEs. I'm alive today. There are people who wrote, well, if Dr. Hunter should get COVID, he should not be allowed in the ICU. There are people who said, well, if you get COVID, the immunity doesn't last. Is it really? That if you survive a condition, your immunity is not going to last? So what's the whole, then vaccination won't be lasting. No, coming back to the media was in a hell of a position, an extremely difficult position, because there is a difference between freedom of speech and a free press. The problem is the big media houses and the small ones are owned by something or someone, and he who pays the piper calls the tune. We saw, I could say comfortably that probably the Ministry of Health was the largest, should I say, purchaser of advertising space over the past 2 years. We heard it constantly, ad nauseum. We heard that you must stay inside. You heard that if you're over 65, you must this and that. And we heard a lot of things from, and I'd like to take this opportunity to say this. It's very important to say this. And this is not said with any disrespect or anything. But Dr. Christopher Tufton is not a medical doctor. He has a PhD in marketing. A third of Jamaicans, from my own analysis, thinks that Dr. Tufton is actually a medical doctor. And he has absolutely no medical qualification whatsoever. Yet we heard a lot more from him than medical doctors like myself. There is a problem there. So who does the media turn to? Well, if I'm paying for advertising space and I'm keeping people employed during a pandemic, there is a problem there. I mean, Dion, you would work for someone. You don't necessarily work for yourself. You would have to kind of pivot to what the overall flavor. Yes, there's
Sorry, stick up in, Dr. Hunter. Let me jump in on something there. But to be absolutely fair, though, in respect to the comment about Dr. Tufton, you're correct. Of course, he's not a medical doctor, but certainly at the press conferences I've attended, and every time I have interviewed him, I can't speak for others. There are others in the room, but he makes a point of saying, let me bring on my technical people, the CMO, the epidemiologists, if it is that you want to ask medical questions. He really does speak to policy issues. So surely that's not an entirely fair criticism.
To answer your point, and you see how you framed it, there is a problem.
How so?
Farmer Joe needs to hear, I am not a medical doctor. Farmer Joe needs to hear, Dr. Hunter is not an infectious disease expert. Farmer Joe needs to know that Dr. Hunter was first qualified as a general doctor and then specialized in neurosurgery. There are people who have a problem with Dr. Hunter actually having a voice because he's not.
Okay, I feel like we're gone off on a tangent because I'm not seeing your point. What's your point?
No, the point is that instead of saying technical, that's technical speech. You need to say, I'm not a medical doctor.
No, it's not technical speech. He's a minister of health. He speaks to curfews. He speaks to policy issues. When we want to ask about vaccines and medical issues, his medical experts speak. And I'm not seeing what's the point you're making here.
I need to understand a third of Jamaicans I don't realize that Dr. Tufton is not a medical doctor. That's the point. So when they listen to him,
to say what?
Because they think he's a medical doctor. He says things that they think is actual fact. He's saying, don't listen to misbelieve, people who actually treat COVID directly like myself and are framed a particular way because we do not come out and endorse and say, I'm vaccinated, take the vaccine. We do not necessarily say that. Then we're framed in a particular way. It's important. Here's the fact that Dr. Tufton is not a medical, nor is
Andrew. Okay, I don't think anything turns on that, but I hear what you're saying. Let me go over to Prof. for him to comment on the false equivalency issue.
Right. So I'm going to speak to that. So as we see in terms of an approach, and which is why when I started my presentation, I tried to give my disclosure, because the issue is individuals, everyone to some extent has some bias in terms of their approach and what is the point that they're trying to make. So the question then becomes, how does the media in general tries to navigate that space so that they are not apparent to necessarily take sides, but at the same point, presenting information to individuals in such a way that they are allowed to make rational decisions and they're not seeing equivalencies where equivalency doesn't exist. Some of that, as I said, has to be the point of the scientific community. We have to take some of that blame because we have not, because of how we're trained, we're often very reticent about communicating with the general public and about having a lot of dialogue with you. And so oftentimes you will find in your own work that sometimes you have difficulty getting what is called the main points. But the truth be told, it's a more fundamental problem. Part of that problem requires us, certainly to start at the high school levels, to try and teach our students. And that is, overall, we need to increase scientific literacy within the country. Because if you're not very literate, then you're not able to understand nuances of arguments, right? And oftentimes what will tend to happen is that you may choose to be influenced by the loudest voice, which may not necessarily be the best voice. So it's not a problem that's easily solved in terms of trying to seek balance. It's not a problem that's easily solved. And what we have to do, those of us who are following the mainstream, is that we have to package our messages so that we can convince our audience that we're not equivalent. We're not equivalent in terms of outcome. We're not equivalent in terms of, we're just not an equivalent footing.
Okay, I have a question here. Do the panelists feel that anti-vaxxers actually were given a voice it says in their countries, so let's say in Jamaica as well as in Ghana? And Nazima, of course, you could also speak a little bit more widely, seeing that I know you monitor what's happening elsewhere. Let me start with you.
I have seen in some cases, not many countries, that and again, I want to say I've not seen a lot of anti-vaxxers in the region. I could be wrong. I've seen more hesitancy, vaccine hesitant persons, and I've seen them being given voices. What I've not seen is a lot of the stories that are not the stories that are out there, not being qualified with any type of information, which obviously is problematic. But I've seen some amount of information out there, and I know that in the cases where they've not been featured by the mainstream media in a major way, they've found other ways to communicate their information. And there are certain targets to that information, particular age groups and particular persons, and they know where to go and find those pieces of information.
Right. I would say that the anti-vaxxers, as defined by persons who are completely resistant to vaccines, so that's the extreme definition. The short answer is that many of those have not been approached on the mainstream media. But the fact of the matter is that they have had their voice. They have had their say. They've used social media, YouTube, whatever it is that is available, Reddit, whatever it is. They have had Twitter, whatever it is. They have had their opportunity to make their point. The truth be told is that those of us who follow traditional science per se, we have not been as active as we perhaps could have been on these alternate platforms. And therefore, that has contributed to a lot of the misinformation being propagated without it necessarily being challenged. And so individuals have not been able to make what I call informed decisions, but rather most individuals have ended up making decisions based on emotional decisions, based on what it is they see and how it makes them feel.
Okay.
And, sure, go ahead, Dr. Hunter.
Yeah, could I say that in terms of Jamaica's reality is that most Jamaicans, absolutely most Jamaicans, are not in love with the vaccines for seasonal viruses like the flu virus, the influenza virus and like the common cold virus, one of which is the coronavirus. We could have said this to the government from the very beginning. Jamaica has absolutely a very poor history of uptake of vaccines for these particular viruses. The flu virus has been around from 1932, yet nowhere in the world is a flu vaccine mandated. It should be put in the same category with the coronavirus vaccine. And
I
the
bet you
coronavirus
disagree there, Roger.
in the
Again, that's an
same
example of
Hold on,
category.
hold on, Prof.
In
Hold on,
the
hold on
same
for me,
category.
Prof. Let me let Dr. Hunter finish
Yeah.
that point,
The
and I'll let you respond.
coronavirus belongs in the same category as the influenza or the flu shot.
Why do you
And
say
in
that?
fact, because a polio virus is totally different virus to a coronavirus. The coronavirus always mutates. It always changes. It never stays still. You cannot vaccinate enough to catch it. Science is just not there yet. It's an RNA virus that always changes. We heard of people losing their jobs in the media houses, forced to vacate their positions because they refused the the coronavirus vaccine.
Sorry, so your
These
major
vaccines
reason.
should not be put
Mhm.
in the same category as the polio, as the measles, as the mumps, as the rubella. Absolutely not.
And your
And
main
in
reason
fact,
for saying that is the rate of mutation? I
it
just want to be
absolutely
clear.
mutates rapidly as we're seeing with Omicron. We're going to
Okay,
learn the Greek alphabet. And
okay.
guess
Let me
what?
let
The
let me let Prof.
coronavirus is not new.
Let me
It's
let
been
Prof
around
read.
for millions of
Let me let
years.
Prof Reed come in and respond. And you are saying you disagree with him on that.
Yes.
Prof Reed is
Again,
Dr. Hunter.
that's an example of what you described of what we call false equivalency. The fact of the matter is that we accept that viruses are different, but we accept that the issue is that if it is that you can create an immune response, then you actually improve your chances of surviving. The data is there. It's very, very clear to everyone. The vast majority, well, not the vast, a significant proportion of individuals who get coronavirus or COVID-19 end up either dying or getting the effect of what we call long COVID, for which we don't know how long that is going to be. And these numbers far exceed the numbers that will happen if you get flu or influenza. So by scale, they're not equivalent. The only thing that they have in common is that they're both viruses. That's the only thing that they have in common.
I beg to, sorry.
Let me let him finish, Dr. Hunter.
I'll stop there. That's the only thing they have in common.
My good friend, this is what I call false information. The influenza virus and the coronavirus, they always mutate. They are fundamentally, that is what they have in common, Mervyn. They have that in common. They always change.
Yeah,
The
isn't
flu
one of
vac-
the isn't
the
one of
flu
the basic,
vaccine this
isn't one
year
of the
is
basic
not the flu
differences?
vaccine from 1932. Is not the
Yeah.
flu vaccine from 1980. Is not the same vaccine from 2000. It always changes. The
Dr.
problem with the
Hunter.
Pfizers and the Modernas is that they cannot get, as Bill Gates said, it
Right.
was
We'd
so
heard
unfortunately.
we'd
It was
heard that point.
unfortunate that the virus changed so much that we got a mild version that conveyed herd immunity. That
Dr.
Omicron is
Hunter,
so
Dr. Hunter,
mild.
hold
So
on
it's
for me now.
important to
Dr.
reject
Hunter, Dr.
that
Hunter, hold
point.
on for me now. We did get that point. You made that point very effectively. I wanted to ask though, isn't one of the more fundamental points that would inform this issue of whether the vaccine should be taken or not, whether mandated or not is another issue though, is the problem we've been seeing emerging from COVID, which we do not see with the flu in terms of what is called long COVID. We've been doing some reporting on that with Jamaicans who have been severely affected. We're seeing it in other jurisdictions as well. And this, hold on. And the science has shown that taking the vaccine reduces the incidence of long COVID. Isn't that
No,
in and of
that
itself
is
a
not true.
significant factor?
Absolutely wrong. Absolutely wrong. We all remember Richard
What is absolutely wrong?
that you don't see long symptoms after a viral infection. To say that you don't say long, call it COVID,
The kind
but
of
there's something
multi-organ
remember-
damage that we see with COVID. Come
Do
on.
you remember Do you remember Richie Richardson, who couldn't play cricket for a whole year? People died from the influenza, and that's why the vaccine was developed, because it was of significant morbidity, but it never entered the category of mandating. Nor should we rush a vaccine like the coronavirus vaccine and say to people, oh, it must be in the same category of the polio, the measles, the mumps, the rubella.
Okay.
We saw
Okay.
one of the largest organizations in the world called the NHS threatening to lay off staff if they did not take the vaccine. All of a sudden, that has been pulled back.
I have some other questions. I have some other questions I want to share. I realize you have a whole heap to say, Dr. Hunter, but I'm trying to get in as many questions as possible. Let me just let Dr. Reed respond to that issue on long COVID and the vaccine, though, before I move to my next question.
So you're perfectly correct, Dion. So we accept, and the data is there, that what you're trying to do in any vaccines, which is one of the things I presented, vaccines are not only there to prevent transmission, which is, I think, a misconception of individuals, but it's also there to try and prevent you from getting some of the serious complications of the acute infection. And therefore, one of the more serious complications, apart from death and the multi-organ system failure and all of those sort of things, is the fact that some individuals who have gotten COVID end up being sick, some of them so sick that they still cannot work for months after getting the infection. And so we recognize that one of the most effective tools that we have to mitigate this, to prevent this from happening, is to be vaccinated. And this is so for almost all the other infectious-related illnesses. The same thing for measles, the same thing for influenza. What we're trying to prevent is disability and death from an acute infection by taking the vaccines.
But probably that what we haven't heard about is the amount of side effects from these vaccines that were touted without telling us what are the long term, the short term, that we do not know the 20-year outcome from taking the vaccines. In fact, Jamaica's vaccination rate for COVID vaccine is truly not 30% or high 20s. It's actually at least half that, because a lot of people who took the vaccine took it because they had no choice. They were faced with losing their jobs. So in fact, Jamaicans' conscientious uptake of the vaccine is actually less. Long COVID is not as common as being touted.
Hold on before you move on. Sorry, I do not understand the figures you just cited in terms of Jamaica's vaccination rates. Can you explain that, please?
You know, when people come to you, Dion, and say, Doc, you have anything that can wash out the vaccine to chelate it? They don't want it in their body. They had to take it because, for instance, if you worked at certain companies, I won't name them on this platform, but we know them in Jamaica, and the Supreme Court actually upheld their position, which is quite opposite of the Supreme Court of the United States, which actually told the federal government that they could not do it to the Americans.
Doc,
what I'm saying,
the vaccination rate, explain what you're saying.
We are talking about what's Jamaica's fully vaccinated rate? 27%, 29%, Dion?
Last I saw was somewhere around there.
Right. What I'm trying to say to you, several people having taken the vaccine, in fact, there are a lot of people who take one dose and they won't take a second.
Right.
And there are people who have taken 2 doses and they want it out of their bodies.
And therefore,
it has caused significant side effects for them.
And if therefore, what does that have to do with the rate?
Therefore, then, what I'm saying is that the rate was falsely elevated because of the pressures to take it, the pressures to take the vaccine. If you're faced with losing your job, or some landlords won't keep you in job, or you can't play Manning Cup football, or you can't run at champs, that's no choice.
All right. In the interest of accuracy, though, what you're describing there is not a rate issue. The issue of the vaccination rate is the number of people who have taken the vaccine per 100,000 of the population. It is. What you're speaking to is whether or not people willingly took it or not. And I'm not going to comment on that. But you can't say that the rate was falsely put out or falsely, or is false. It is
what I'm saying. People were kind of motivated more into taking it because of
that's what I'm saying. If you want to speak to motivation, that's one thing. But you can't suggest. You can't suggest that the rate is not what it is.
I am reporting back to you and your audience here, and it's important that Jamaica understands it. Several people who have taken the vaccine they regret taking it. In other words, they regret taking it.
You can't
We're not
conflate
confusing it.
issues.
We're
You're
just
conflating
no,
motivation with
no.
rate of vaccination. It's two different
But
things.
the point is, the majority of Jamaicans, Nazima, have not taken the vaccine. Let us be
Okay.
very clear of that. And this
Okay.
is not Guyana. This is not
That
Israel.
is no, that is
That's
a
a
fact.
fundamental
That's a
fact.
fact. That's a fact. Nazima, let me bring you in here with the
70%.
next.
You
Let me bring
can
you in
spend
here with the
2
next
years
question.
marketing. It is going to be dumped. Millions have been dumped already.
All right, let me bring in Nazima with the next question. What lessons should policymakers have learned now in relation to people with alternative views on issues such as the vaccine? What
The policymakers have to talk, Dion. They have to be more open. They have to understand the rules of engagement and communication. I think that has been lacking, and we see that around the region. The types of information, the types of discussions that need to have, they have to facilitate it, and it comes back to them and what they do, and that whole communication process it has to start with them. I know the media takes on a lot and has taken on a lot when it comes to facilitating engagement already on the pandemic and so many other issues, but the policymakers got to step up.
for you?
The difficulty with stepping up. Oh, sorry.
Yeah, let me just go to Professor Reed, then I'll come back to you, Dr. Hunter.
Right. So one of the things I just want to put in context is this whole issues of numbers. Numbers are what the numbers are, and they speak for themselves. So we know what the numbers of individuals who have died from COVID, and even then those numbers are even underestimated. But we have a number. We know how many persons have been vaccinated. We know how many persons have died, and of that proportion, how many of them have been vaccinated versus those who have not been vaccinated. This COVID-19 vaccine, at least 4 billion persons in the whole world has received it. We recognize that of that 4 billion, some number of them will experience some side effect. The truth be told is that the proportion of individuals who have had significant side effects are much, much low, relatively low, compared to the individuals who have actually benefited. Now, what the argument that Dr. Hunter and people like himself would like to make is that they will focus on the 1 or 2 persons who have had a side effect, and then you will have a headline. But the long and short of it is that the numbers are the numbers.
Dr. Hunter, please, let me just let you
So as a policy perspective, so the issue, no question, is what do we say to our policymakers? The policymakers, you see, if you try and suppress individuals who have contrary views, oftentimes you end up fueling this whole conspiracy theory. You become opaque, you're not transparent, and therefore it contributes to a lack of trust. On the press side, it's equivalent to almost a censorship. So I'm not adverse to having discussions, but one of the challenges that we face in having these discussions is really to try to make those of us who are not experts in the area really understand fundamentally what the issues are. Because sometimes what is happening is that we have what we call a conflation of the issues. And so you mix motivation, you mix things so as to make a dramatic effect. But the numbers are the numbers. They speak for themselves. This drug has been utilized more than any other drug as a class. And the number of persons who have died from it, who have had significant side effect from it, is very small compared to the number of persons who have died from the natural disease. And that's the number.
Is it not true though, Professor Reed, would it not be fair to say the point that Dr. Hunter was making, that there has seemed to be a reluctance on the part of those in official to speak to anything that's negative about the vaccine? So because there has been this desire to get the population vaccinated, to protect people, that you really, when people ask questions, Zara Burton, for instance, is somebody who has been asking regularly about things like side effects of the vaccine, things like, even the issue of how it affects women and their menstrual cycles. That's not something that was brought to the fore until women started saying, hold on, I've seen something happening. Have you seen this? And then after that, we heard the experts come out and say, it's not unnatural. Your cycles will return to normal in a couple of months. Don't worry about it, kind of thing. But there has seemed to be a reluctance to say anything negative, perhaps because of the
Uh,
concern about the hesitancy. Let me let
the-
Dr.
um,
Reed answer that. Then I'll ask
I wanna,
Nazima to comment on that, and then I'll come back to you, Dr. Hunter.
mm,
Sorry, you're asking me to comment. So the short answer to
Yeah.
that question is yes, there's been some degree of hesitancy, which is a strategic mistake, I would say, about describing what are some of the side effects that one will see. So in any clinical trial, one of the important outcomes of that clinical trial is to be able to get an idea of what those side effects are. But we know when we scale up any treatment from a clinical trial to a much larger group of individuals, that there may be additional or new effects that we didn't see in the clinical trial. And so, as part of the process in any drug deployment or any intervention deployment, is this process of what we call vigilance. In the drug world, they call it pharmacovigilance. So, if I'm a practitioner, which I do, and I see a patient and they report that they're having A problems with the medicines, one of my responsibility is to fill out a little form, send it to the ministries and say, I have patient X who has reported Y. And what we then do with those information is that we look to see if there's any pattern. And we look to see if there's any signal coming up from all of these reports. And that's how it is that we were able to describe in the early days that blood clots may be an issue. We were able to describe in the early days that individuals may have significant allergic reactions. That's how the process works. It doesn't mean that we're necessarily trying to hide. What we should have done is communicate to individuals what the process is, so that they themselves are engaged in the process and participate and share information with us more willingly. That's okay.
Nazima, let me
Right.
bring you in here. What have you
Yeah.
found when you sought to, you and your colleagues, for instance, ask
Yeah,
questions?
so at the very beginning of the vaccination process, we had done some training on, understanding vaccine, the history of vaccines, and so on. And one of the major issues was really getting information on side effects. With any medication, there are side effects.
Yeah.
And trying to get that public accountability on side effects was an issue until people started to talk about the side effects they were having. The menstrual cycle issue was certainly one of the things. And I remember posing that question during an interview I had at the very start of it. What were some of the reports we were getting? And there was no indication that, that was an issue until a couple of months after.
Yeah.
So certainly, and this is why engagement with these experts and professionals are so important. I have to reiterate that all the time.
I, thank you. Can I respond now?
Please, Dr. Hunter, go ahead.
First of all, it is a disservice to the listeners to say, oh, one or two side effects. There are many, many side effects. When you have the head of one of the most important hospitals in Jamaica is afraid to report that her mother had to, well, the person had to be out of Kingston, had to be, had to be nursed after taking the vaccine, and they felt impaired to report into the government architecture. It tells you there's a problem. When we see South Africa reporting, oh, the Omicron strain has emerged, and the world responded by blocking them. Can you imagine little Jamaica reporting a Kingston strain? What do you think would happen to it? The problem is that it's not a simple matter of science. People react to the data. And the scientists they know this, they're savvy. Professor Mervyn Reed knows this. So how it's produced. University of the West Indies was a classic example when we had one of the most renowned professors in the history of University of the West Indies, Professor Bain, reporting a particular study, what happened with HIV. And the vice chancellor telling him that if you report to the courts of Belize, I think, you will suffer a harm. And he did suffer a harm. And Professor Bain's only redress was the Supreme Court of Jamaica, who gave him a Pyrrhic victory. No, this is not a simple matter. Several people have been affected. And, they say, well, this doctor has been on the news advertising and for the Ministry of Health. They're not going to come to you, Mervyn. They're not going to come to you. They're going to go to somebody else and tell them. But what is also clear that the mass of Jamaica, the Association of Independent Public Health Providers, have not been given a voice in the media space. Compared with the voice that doctors who had government contracts compared with their voices or had university contracts. So it immediately tells you that there's a problem, that underreporting was going to be a fundamental problem with the study. How can you say that after 1 year or 2 year or even 15 years, we are proud to say that this mRNA is safe when we don't know, giving it a 2-year-old, what will happen in 20 years? No, this is something that must be met with very clear ventilation of the issues that we do not know. We cannot tell you what will happen to your child in 20 years from now. We cannot tell you what will happen to you if you're 40 in 20 years from now. What I can tell you is what my pathology friends have seen when they do postmortems and they're seeing long rubber. We're not talking about side effects here. We're talking about death, who have gotten the vaccines and died. People whose vaccination cards have suddenly disappeared after they have died. And the underreporting and suppressing because of fear that if this information gets out there, people will not want to take a vaccine for a seasonal virus, which the country already had a problem with.
All right, you said a number of things there. Sorry, before Professor Reed comes in, I just need to comment on a couple of those. You threw in the Omicron discovery out of South Africa, which really doesn't belong in this conversation. The blocking there was due to the fact that people saw another virus emerging and they started to block South Africa from moving.
Variant.
Sorry, I'm not sure how you compare that. I'm not sure the point of the Omicron point in your discussion.
The point is very clear. That
no, it actually isn't. It actually isn't. That's why I'm
clear as day. Just clear as day. And the fact that you haven't seen it.
Dr. Hunter, listen to me now, man. Listen to me now so that you know what you're responding to. I am saying the discussion is about side effects and whether or not they are given space for discussion and exposure. I'm saying in relation to South Africa and the Omicron variant, what happened in that case was that South Africa discovered the Omicron variant and people closed their borders to South Africa, not because they didn't believe in the variant, but because they didn't want it spreading. So I'm asking you, what's the point you're making in relation to Omicron?
The point is this topic. The point is the whole toxic topic. We're talking about something that is very... I'm going to laugh at you too, Mervyn. Don't worry. The point is... we're going to laugh, but we know this is a serious topic, right? That's why we're here today, Friday and not Monday. People are watching. The fact is, what happens with the vaccine? If it says that Jamaica had a number of side effects on the vaccine, the ministry might be a little reluctant to announce the information. Zara Burton had a little bit of a challenge getting the information about the side effects of
you
vaccine.
Realize this has nothing to do with your South Africa Omicron point.
You realize that this has everything to do with a wider discussion. Okay. You understand that?
All right. Okay, I realize you decided not to play that ball, so let me move on. The issue of Professor Bain, let me just say as well, that was a case I covered, and the concern with the Professor Bain case was that the people who objected to his publication, and you can all go and read the report, the concern was that the science was not good and the science was outdated. So let me just make that point for my listeners who weren't following that.
That's fair enough.
All right. In relation to the issue, you said that independent public health professionals did not
like myself
have voice in the media. Absolutely. Well, let me ask you though, how would you, because what happens in media, right, is that you tend to go for association heads. So for instance, we would speak to the president of the Medical Association of Jamaica consistently. The former president as well as the current president are always being interviewed. You speak to public health people who have expertise in the particular area. You speak to epidemiologists, you speak to the Ministry of Health, you speak to the Jamaica Medical Doctors Association in relation to the impact on their doctors. It is not normal to go to a random doctor talk about their individual injuries, because what you're trying to get is a wider picture. So what are you suggesting should have been done? We just call Dr. Brown and Dr. Green and say, come and talk to me about this particular issue in which they have no particular area of expertise. How do you
these political campaigns have been made and broken on these simple things. Speak to Farmer Joe. Speak to the man out there. Speak to the GP who's actually out terribly treating these patients. When the Ministry of Health say, we will send ambulance for you, don't worry, we lock down Portmore, there's no more ambulance coming. What is happening to the frontline doctors? We're all hear about this. Thank you, frontline doctors, when the GP is a frontline doctor, for God's sake.
And there's an association of general practitioners who also was represented in the news. I'm not saying you're wrong. I was just responding to you in terms of some of
we have not gotten similar standing.
Okay.
And that's an important point to accept. And because a lot of that, for instance, through our advocacy, we finally heard about early home-based interventions for COVID. We're told to isolate by the Prime Minister and watch yourself for 2 weeks. And then we realize, actually, if you start interventions early, which is a fundamental part of medicine, you can actually prevent deterioration to severe illnesses. But I'd like to come back to make a little point about vaccines.
Professor.
I want to come back and just want to make a point.
For a long time. I need to let.
I haven't as much as Professor Reed has. And there you go again. This again suggests the problem with the coverage.
Hold on. If you go home and time the broadcast, I think you'll see how much time you got.
I won't do it, but I'm confident.
All right. I just want to speak to just one point, and this whole concept of home-based therapy as if it was a new intervention. The truth be told, from the onset of the epidemic, we have had, this is the Caribbean College of Family Physicians, the Association of General Physicians, we have had meeting, training on how it is that we treat individuals from very early. From very early, we recognize that there will always be a spectrum of cases, those that require hospital and those that require treatment at home. So home-based therapy is nothing new. There's nothing magical about it. As doctors, we have all been trained to deal with it. And we have had our own internal meetings and forums where we have had those discussions. So I just want to put that on the table. And we have had that. The first session that we had was in March of 2020. Right soon after the outbreak reached Jamaica. So that's nothing new. And as a matter of fact, we even had a session in January before the virus actually reached Jamaica. So what Dr. Hunter is alluding to is really a misconception.
That's not true, actually. It's very fundamental that the ministry's message was never about early home-based treatment. It was always about watch yourself, don't do anything, just watch yourself for 2 weeks. And when you get really sick, stay home, isolate. And when you get really sick, then we will, having locked down Bull Bay or Portmore, we'll come and get you. And we're hoping soon that there'll be a vaccine on the horizon, but we'll come and get you. And this is how we'll deal with a pandemic. And we'll quarantine the rest of your contacts, which obviously didn't work, was never going to work. No, actually, there's no early home-based message in any. And you know what? The evidence of this? Doctors were actually running away. It's the greatest failure of primary healthcare in the history of Jamaica. I know no other history where you had general practitioners, specialists right across the board literally close their offices. We need to talk more about it.
Yes, but aren't you
literally
run away? But you can't look at March. Hold on. Listen to me, Dr. Hunter. Listen to my question. You can't look at March, where are we now? February 2022.
2 years ago.
No, sorry, the other way around. You can't look at March 2020 through the spectacles of March 2022. At the beginning of the pandemic, of course the doctors were scared. Everybody was scared.
I was not.
Good for you.
Good for you.
Congratulations.
Jordan Ferron died.
My doctor, who was a GP, died
Tell me
of
about
COVID.
it. I'm not sure about that. You keep saying it. Absolutely not. His brother died this week of a sudden cardiovascular event.
Dr. Hunter, could you stop?
Donovan Jackson died this week. His father died of a heart attack. Did he really die from COVID?
Dr. Hunter.
I'm not sure he did.
At the beginning of the pandemic, right? Nobody knew much about this disease. The science was evolving, the treatment was evolving, the issue of home-based treatment, which is now widely accepted, at the time was not. It also evolved.
Oh,
So surely you have to take that into account
no,
when
I
you're
don't.
making the
I reject
assertions you're
that.
making.
I reject that, and it's important to reject that because let's just look at some fundamentals of this condition. Well, I told you we need to speak long on this topic.
We're so
When you talk about 2020, the total number of deaths in 2020 were less than 2019, and the total number of deaths there was no excess of deaths. I know of no year where there was an excess of deaths in Jamaica. So we need to go back and re-examine what is really being
I
called
don't know what you're
COVID.
I don't
saying.
know what you're
In
talking about.
2020 was
Of
less than
course you don't
2019.
know. Just like in 2020, you didn't know what I was talking about. You're running away. You closed your office and said you knew nothing about COVID. The point is, coronavirus is not new. It was always going to mutate. When the WHO said that you didn't have to wear a mask, everybody didn't wear a mask.
You
And
see,
then the
the difficulty we're trying to guide the discussion is that in one
it's a
paragraph you
complex
said 10
discussion.
different things.
It's in fact, I want to tell you 100 different things.
I can see that. Hold on. You wanted to come back in, Professor Reed?
No, it makes no. I'll pass on this one. Just ask a question.
Yeah. All I was saying, and I can tell you as someone who got COVID,
So did
pretty
I.
seriously, early on in the pandemic, at that time, there was not a lot of home-based treatment going on simply because people
Dion,
did not. Hold on, let me finish. Let me finish what I'm saying
I'm
now.
going to compliment you. That's what I was going to say. I was never going to be worried about you because the last time I checked, you're pretty fit. You're pretty healthy athletically. From what I can see, I know nothing about your
Okay,
background medical
one
history.
of my colleagues who is far fitter than me is now suffering seriously as a result of having had COVID. So I hear your point, and I know
But
this is something I know this is
we
something
need
you've
more
been saying.
time to discuss that
Yeah.
topic as well. Like
Okay,
maybe
we're
general.
gonna be we're gonna be wrapping soon. So let me start to I'm gonna be asking each of you soon for your closing comments, and then I'll ask George to say a couple of words at the end. But let me ask you before I ask you for your closing comments, Professor Reed, what's your takeaway from all of this?
My takeaway from all of this is that the 2 years has highlighted some deficiency in the process. The process in terms of how we as scientists communicate information. But in highlighting that, I hope our audience understands a little better how science works, and that science is never static, and that there will be ups and downs. Nevertheless, when it comes to vaccines and as a medicine, especially when we speak about the COVID-related vaccines, certain things are very, very clear to us. One is that the vaccines work for their intended purpose, that is to prevent serious illnesses. Um, they work in a variety of circumstances, and we accept that, as with all medicines, there will be some side effects. But the truth be told is that similarly for any medicine that you can think of, whether you think of your blood pressure medicine or you think of your diabetic medicine, the fact of the matter is that if the benefit outweighs the side effects or the risk, then as an intervention, we will always recommend this because the benefits that accrue to you is much better than the risk that you face. In addition, because it's an infectious related illnesses, our own actions will affect our brothers and our sisters, our family members. And so it is in our advantage to try and as much as possible to act responsible and also to encourage our brothers and sisters to act responsible by taking the vaccine, because only if all of us are vaccinated would we have a chance in trying to make sure that we eradicate this particular illness. We recognize that there are certain issues with the virus which would make this a challenge, but notwithstanding that, as I said, the data that we have so far seem to suggest that we can overcome if it is that we all act in a responsible manner. Having said that, I will always be willing to accept listening to individuals who have contrary opinions, and I'll agree to disagree. But the
Right.
issue is that science is based on evidence, and evidence, as we say, will continue to evolve.
Could I just quickly respond to Marvin's just quickly by saying this. science is evolving, which is, in other words, to say that it's not a firm, solid foundation, unfortunately, Diane. So you still have to make your own decision. And I encourage people to look at their structural health, their background health, like yourself. I wish Dr. Lenny Jackson, wonderful guy, lovely guy, had your sort of background health. I wish he had it, because he did have a heart attack a few years ago. But the point is this. We would be best advised to look at the Omicron as the reason why we have had a reduction in the severity of COVID throughout the world, and not attribute it to the efforts in vaccination. And we need to look no further than Haiti or mainstream Africa to see that people who had virtually no vaccination had the lowest deaths from COVID. And we accept you cannot hide a COVID death, because the shortness of breath is there. People die from respiratory illness like that. So you can't hide it. Sure, you may not have a positive COVID test, but you'll see an increase in COVID deaths. But let's just be clear that the virus is always going to mutate. And thanks to the mutation, we are seeing a wonderful reduction. And of course, early home-based treatment, which was never promulgated neither by the WHO or by our CMO in the very beginning, despite utterances and urging. I yield at the moment.
Nazima.
Thank you so much. Look, my Friday night is so rich. This discussion. We usually get treated to some good blackouts here in Guyana, so I was lucky to be spared that and to be part of this rich discussion. But I wanted to say that it is discussions like this, continuous discussions, that are needed. And it is good that two professionals were able to come within this forum to discuss issues that are being already ventilated in the public and people need information on. They need to hear your views on this. And Dr. Hunter, I'm hoping to see more of you on mainstream media. I know you have your own YouTube, is it YouTube or Zoom?
YouTube.
Okay.
Zoom. Stream
Yes.
on YouTube.
Yes.
I hope
The
it's
type of
tiring though.
engagement are definitely what is needed. As you and both Dr. Reed said, that the virus is evolving, and so will reporting on it will be evolving. And this is why we need access to information, and we need access to experts, and we need access to all types of literature on it to report on it. So I was very pleased to be part of this tonight. So thank you for inviting me.
All right. Thank you all so very much. And let me ask George to come and wrap us up.
Thank you very much. I was saying to Dion on the WhatsApp that, it's a pity that we didn't have the audience numbers that we had for Tuesday Monday rather, when we convened originally for this, because those who weren't here, they really missed something. It was an intellectual treat, a battle of wits, a battle of perspectives, and people really making an effort, not just here for show, but to represent their views and to present their arguments in such a way that even if you disagreed with them, you at least understood where they were coming from. And I really appreciate that. So I thank our panelists really for taking the time to make this a rich evening for me personally. And fret not, we'll be sending the recording stream, the link, to as many people as we can for them to enjoy what we certainly enjoyed here. So I really thank you for your time and your effort and your expertise. And thanks also to Dion for marshalling the conversation in the way that only she can. Thank you again.
All right. That's where we leave it for today. And let me just remind everybody, tomorrow is going to be our National Journalism Awards. We also will be streaming it live. So we do invite you all to tune in and to watch. And let's see who's going to take the top prize, who's going to be Journalist of the Year. Have a very good evening.